Hello guys, welcome again to the second session. So today's session is going to be on the second part of AIIMS 2021 oncology questions. Yesterday we discussed about half the questions which were already there, and today's discussion will be a continue of that. So today's session we'll start off with this question. So what is the most common RCC in end-stage renal disease patients? That is the question that was there. So what is the most common RCC type that is found in end-stage renal disease patients? Papillary. Okay, now there is a slight difference. Many people have marked it as papillary. Now, if you look up the resources that we have, the answer that I could find out for this particular question was actually the clear cell type. Now, if you take up end-stage renal disease patients, you have the most common type in patients who are greater than 10 years of dialysis. The most common type of RCC that you get is one type called as the acquired cystic kidney disease protein. So acquired cystic kidney disease type of RCC, which is actually the one which is found in more than 50% of patients. This is characterized by a cribriform architecture and also by the calcium oxalate crystals. Now, the most common RCC in patients with end-stage renal disease and dialysis less than 10-year type is actually the clear cell RCC. It's the conventional RCC which is found to be present in most patients when the dialysis period is going to be less than 10 years. More than 10 years is the ACKD type. Now, in patients, since this is not clearly mentioned and since we do not have the ACKD type being given here, I think we'll have to go with the choices clear cell RCCs. There were some articles which also quoted the papillary RCC, but if you look up the number of patients in most other articles and texts that I could go through, the answer that kind of matched everything was the clear cell RCC in this particular option. If we have the option of ACKD type of RCC, then that is the best option. If not, then it has to be the clear cell RCC. Any doubts with regard to this question? Because this was quite a lot of controversy that was there. Yeah, someone has marked it as, Deepak Lal has marked it as clear cell RCC. So the answer to this question that I could find after going through multiple references was this. Any other sources given where it is clearly mentioned as papillary RCC? Because I couldn't find a definitive book reference kind of thing where they have mentioned. It's multiple articles through which I got this reference. So what I could deduce was clear cell in patients where it is less than 10 years of end-stage renal disease and dialysis. And otherwise, it is going to be the ACKD type. That is the acquired cystic kidney disease RCC type. So if that is mentioned, that is the best choice option. If it is not mentioned, then I think you should go for your clear cell RCC. That should be the type that should be mentioned. So now let's go on to the next question. Bailey and Campbell. Bailey, there was actually, okay, I didn't actually look at Bailey also. Maybe it is mentioned there. I'll have a look at it because sometimes the simpler books might have a smaller option which is there. I will go through it, but based on my research, you can say the answer was clear cell. Though there were a few articles that mentioned about the papillary RCC also. In fact, I almost marked papillary before going through multiple other articles which actually mentioned clearly as the clear cell or the ACKD type. This is in all the recent studies, whatever we have, everything is showing only the ACKD RCC is actually the type that is found most commonly. So I will have a look at it because Devita does not mention. Campbell, I need to have a look because again, I couldn't find a clear talk of this one. I didn't have access to Campbell, so I will do that as well and then I'll check it up. Okay, right. Now to the next question. So HMB45 is a tumor marker which is seen in oncocytoma, angiomyolipoma, RCC, and in papillary RCC. So where does your HMB45 come as a marker? Now this was a very clear question. Most of you are answering it right. So it is found in angiomyolipoma. So where else do you get this HMB45 as a tumor marker? IHC for HMB45, where else do you use it? Melanoma. Yeah, classically we'll talk about it in melanomas. So which is the most sensitive marker for a melanoma? Is it melan-A or is it HMB45? That is one question that keeps coming repeatedly in multiple examinations. So which is the most sensitive marker or IHC marker for your melanoma? Is it melan-A or is it your HMB45? That is one question that comes. Yes, for that the answer is going to be melan-A. Okay, so that is what we have to mark it. So in this case, it is very clear. Angiomyolipoma is the entity that we are talking about it. So in various sites, angiomyolipoma, it is usually found that melan-A is also positive, HMB45 is also positive. So other than melanoma, it is found HMB45 is going to be found in patients with angiomyolipoma, clear cell sarcoma of the soft tissue, which is something similar to what we'll get in, similar to your melanomas. Then you have epithelioid sarcomas where it is occasionally found. You have lymphangioliomatosis, and then you have your melanocytes and picomas where it is going to be present. So all these are the cases where you will have your HMB45 as a kind of staining marker that is going to be found. So the other alternatives that may be asked are going to be your clear cell sarcomas may come as an MCQ, picomas may come as MCQs. All these are other areas where you will have the HMB45 which is staining positive for you. S100 is not considered to be the most sensitive or specific marker. It is HMB45 and your melanin which are going to be more relevant as far as the IHC staining is going to be concerned. So, oh my God, right. So post-radical nephrectomy, the recurrent site, which is the most common. Many of you will already know the answer to this one. In fact, it has come up here. It's not actually the renal fossa, it is in the lungs. Renal fossa metastasis after radical nephrectomy coming back with the local recurrence in the renal fossa is a relatively rare phenomenon. It is common in multiple things, but it is one of the other common sites, but lung is the most common site where you will get the recurrence that happens after radical nephrectomy. Here the question was on radical nephrectomy. Partial nephrectomy, yes, you will have a higher incidence of what you can say as the renal metastasis or the renal recurrences or the renal fossa recurrences will be more common. So the doubt here will be between renal fossa and the lung. For this, the answer is going to be clear cut. It is the lung. So the source is again, the time taken is around 1 to 2 years and most of them occur within the first 3 years. So lung metastasis is the most common site, happening about 50 to 60% of patients. This was in the discussion part in your NCCM where there is a reference to this, right? Stauffer syndrome, biochemical abnormality which is not seen. So all of you will know about the Stauffer syndrome. We know that classical Stauffer syndrome is characterized by RCC without liver metastasis, but it will be characterized by your normal bilirubin. There is no evidence of rise in bilirubin. You do have a variant where you have icterus associated with your Stauffer syndrome. That is another variant which is going to be there. So you will not have an elevation in bilirubin. When you talk about plain, which is mentioned as Stauffer syndrome alone, you will not have an elevation in bilirubin. So when you have an elevation in bilirubin, it's the icteric variant of the Stauffer syndrome that you're talking about. But characteristically speaking, you will have elevation of AST, ALP, and your ESR. All three will be characteristically elevated. There is liver dysfunction in the absence of metastasis. That is the characteristic feature that you find in your Stauffer syndrome. So in RCC, no liver metastasis, raised cholestasis markers of ALP and gamma glutamate transpeptidase, prolonged PT, you have low albumin. All these were some of the features which we have mentioned in the classical Stauffer syndromes article. In fact, I had a look at the original article as well. So in that, you are able to find that the bilirubin is mentioned to be normal. There was a very good review article. This is the article which I have quoted here. So there they compared the various things. There is an icteric variant which has been recently detected. Only about about 50 odd cases or something they have mentioned about the icteric variant. When you have the icteric variant, there you will have an elevation in bilirubin. But the classical Stauffer syndrome will not have an elevation in bilirubin. Okay, right. So robotic surgery. Now this question, I was not sure what was the actual question which was asked. Okay. Can someone just put it up in the chat box? What was the actual question which was asked? It is used in kind of thing was there, but I'm not sure. Used most commonly in, not used in. What was the actual question? If it is asked as where it is most commonly used in, then the answer is very clear. Then it is going to be your prostate. Okay, okay. So most commonly it is going to be used in prostate. So that is the worldwide. If you look at it, the most common surgery which is going to be done by using a robotic surgery is going to be your robotic radical prostatectomy. So then the answer will be clearly your prostate. So here the most common use of robotic surgery is in prostate. What about colorectal, gynecological, and esophageal? Yes, all these sites are also there. All these sites are also now being done. So a bit about the robo itself. So they may ask you what is the first generation of the robo. The first generation is just known as the Da Vinci S. Then you had the Da Vinci SI. Okay, so you had the Da Vinci S and you had the Da Vinci SI. So the most or the latest system that you have is going to be, please don't write on the screen, my dears. So that is going to cause everyone to have it. So please do not write on your screens. You can just note it down in your separate things if you want to. You have the S, which was the first type. Then you have the SI system, and currently you have the XI, which is the most commonly used system. Okay, so these are the systems which are commonly used. This is with regard to the Da Vinci robot that we are talking about. Okay, so the Da Vinci robot will have multiple iterations have come. This is the third generation which is currently being used. So the XI is the latest Da Vinci system that we are using. So XI system is is the latest one. And can someone tell me what was the first system that was devised? What was the name of the first system which was devised? Puma, Probot. Okay, I think the answer, if I'm not wrong, is the ESOP. Yes, Varun has got it right. The ESOP was the first system which was devised. So ESOP was the first system which was used practically, and after which came the other systems, the Promot. There are multiple systems which are available. When we talked about the XI or the SI, all these are the Da Vinci robots which are predominantly used in various sites. But you do have separate robots for neurosurgery, for robotic neural navigation. You have separate robots which are available for orthopedic surgeries, for joint surgeries. All this is there. And you also have a lot of, surgeries where, like for example, in cardiac surgeries, it is very commonly used. But in cardiac surgery, the problem is going to be, the patients, the adoption of robotics for cardiac surgery is not being so wide as compared to the other areas. In the abdominal and in the thoracic areas, it has been widely adopted, but not so much in the other areas. So the most common surgery which is going to be done is, prosthetic surgeries, followed by the other pelvic surgeries like gynec and the colorectal surgeries. Esophageal and other thoracic surgeries, it is done in a limited fashion. It is not done so widely, but it is done in a limited fashion as far as today's use is going to be concerned. So carcinoma ovary 7 centimeters in size with omental metastasis 1 to 2 centimeters. What is the staging? 3B, 3C. Okay. So C is the answer. Okay. You have gotten it right. C is the correct choice. So it is stage 3B. So all of you know that when you have microscopic omental metastasis, so when you have microscopic omental metastasis in carcinoma ovary, that comes under your stage 3A. When you have deposits which are macroscopic and less than or equal to 2 centimeter, it comes under stage 3B. Anything more than 2 centimeters in the omentum, that is going to be coming under stage 3C. So that is how you will classify. Now AJCC is one area where definitely at least 1 or 2 questions will come from the various things. Again, I will tell you here that you need not remember and mug up everything in the AJCC. It is good to do that, but it might be a little difficult. It is confusing. It keeps changing. So it is not going to be that easy for you to remember everything as far as AJCC is concerned. So whenever you attend the classes, that is why I've actually, highlighted the areas which are going to come for you, which are going to be the important areas which are there, not really everything you need to memorize. There are some areas from which they will ask you questions commonly, and then look at the updates. So whichever thing is going to be a little different from the previous staging, from that the questions will definitely come for you. So one other question that comes routinely in today's this one will be involvement of pelvic and parietic nodes. For example, is stage 3A as far as ovary is concerned. So most of us will tend to go and mark it as a stage 3C. In all other sites, it will be stage 3C, like cervix, endometrium, etc. But when you take up your, cancer of the ovary, retroperitoneal nodal involvement, which includes both the pelvic and the parietic nodes, both of this, it is going to be. So involvement, they may ask you like, involvement of the pelvic node is what? Involvement of the parietic node is what? Just remember, for everything, the, the pelvic or the parietic nodes, any retroperitoneal nodal involvement in your carcinoma ovary is going to be a stage 3A. It is not stage 3C, it is stage 3A. Okay. So borderline ovarian tumor, which is the true statement? I think this is what should have come as the question. Again, I'll be glad if somebody can, highlight and say what was the actual question which was asked. So borderline ovarian cancer, which is the true statement? The stroma is not involved. Oral contraceptive pills decreases the risk. Complete resection is the treatment, and it is related to your BRCA. So which do you think is the true statement with regard to borderline ovarian tumor? Someone wants to take this? I've just framed it in a way that there is a definitive answer to this question. It is all except, which is the false statement they have asked. No, the question was, is it stroma is not, which is the true statement or which is the false statement? What was the question? Yeah, the question is with regard to the true statement. Only then it can make sense here. Otherwise, we'll have to change all the options. So if you look at it as an option, let's take it each one by one. So in borderline ovarian tumor, do you have stromal invasion or not? There is no stromal invasion. That is what is given. So is that a true statement? Stroma means we are talking about the ovarian stroma here. We are not talking about the other stroma. So ovarian stromal invasion is present because you will have a component which is going to be there, which is coming up from the ovary itself. So that ovarian stromal invasion is definitely there whenever you have a borderline ovarian cancer also. It is dependent on whether you have other areas which are going to be there or not. That is going to determine. Okay, so when you have other areas of involvement, that is going to determine whether or not you're going to have a borderline ovarian tumor or an invasive classical ovarian carcinoma. So that is going to determine. It is not based on whether stromal invasion is present or not. Stroma is always involved. Okay, so this statement is clearly wrong. Stroma is not involved is a wrong statement. So OCPs decreases the risk of borderline ovarian tumors. Now, what we have to understand is borderline ovarian tumors have different set of risk factors when compared to your classical ovarian carcinomas. So OCPs decrease the risk of your classical ovarian carcinomas, but they have got no role as far as the prevention of borderline ovarian tumors are concerned. So OCPs do not decrease the risk as far as borderline ovarian tumors are concerned. The same way, the role of BRCA mutations in borderline ovarian tumors is not known. Borderline ovarian tumors are not something like, they are the precursor lesions and then you have the development of ovarian cancer. Compared to all other areas, your borderline ovarian tumors are not like that. So here, what you have to remember is they are not related. They do not have any relation to the BRCA. So if you talk about BRCA, then what is going to be the classical lesion that you will expect in a patient with a BRCA mutation, which is considered to be pre-invasive as far as the ovarian cancer is concerned? Do you want to take that? When you talk about the initiating, pathological finding or the pre-malignant lesion as far as your BRCA mutations are concerned, can someone type in the chat box what is the pre-malignant lesion that you will get in BRCA? Yes, guys, you got it right. It is STIC. So serous tubular intraepithelial carcinoma or STIC is going to be the precursor lesion. Currently speaking, we consider STIC to be the precursor lesion for almost all ovarian carcinomas. Okay. So the reason is when you have your BRCA induced carcinomas, when you have BRCA, when you do a risk reducing salpingo-oophorectomy, you find that these patients have pre-existing lesions that arise from the fimbrial end of the fallopian tube. So these lesions have gotten a name now, which is known as your serous tubular intraepithelial carcinoma or STIC, STIC for short. They stand as the precursor lesions. Borderline ovarian cancers are not really considered to be your precursor lesions. So when you consider borderline ovarian tumors, you have to remember some points here. So complete resection is going to be the treatment. Now, fertility preservation surgery, whether you need to remove the ovary of that side alone, or the way you need to do a complete staging, that is a controversial thing. But in general, most people will prefer to do at least a TAH plus BSO for most of these borderline ovarian tumors. Suppose you want to do a fertility preservation surgery, then you can do a unilateral salpingo-oophorectomy also. That is also justified. The next question that will come is in a patient who has a borderline ovarian cancer, which is detected incidentally. So in such cases, what would you like to do? Will you go ahead and complete the resection or can you observe? Here again, it is preferable to complete the full staging. The staging procedure for borderline ovarian cancer and for your, routine, what you can call a staging laparotomy for ovary, both of them are the same. The steps are all the same. Initially, you will make a midline incision. You will assess the entire, abdomen fully by inspection and palpation. You will do peritoneal cytology, and then you will do a TAH plus PSO. You will send it for pathology by frozen section. Then you will do pelvic lymph nodes, parietic lymph nodes, omentectomy, at least an infracolic. This is the gross steps, and then you will do your peritoneal biopsies. So these are the gross steps that you have as far as carcinoma of the ovary is concerned. So when you take up your borderline ovarian cancer, all these steps also are needed. So the conventional treatment for this is not any different from what you do for this. But what we need to remember is they are much more indolent tumors. What can be seen is usually they are of the serous type or the mucinous type. The stroma is involved by the tumor, but there is no peritoneal invasion pathologically. On the other hand, you can have something called as invasive implants. The presence of invasive implants does not mean it is an invasive ovarian cancer. Okay, so depends on the extent of peritoneal invasion that is going to determine whether it is going to be called as a peritoneal peritoneal, what you can say as classical invasive ovarian carcinoma, or whether it's going to be called as a borderline carcinoma. So that differentiation, borderline ovarian tumor. So that differentiation is ultimately made by pathologists. It is not something which you can make it on the table. You will send it for pathology. In fact, by looks, it can look very similar to your borderline ovarian tumor. There will be no difference between the two. So as far as omentectomy and node dissection are concerned, many of them will get upstaged, and up to 30% by doing both these procedures. If you do, around 30% will get upstaged. But whether you need to do anything different based on this, no, usually you do not do anything different, because the treatment is going to be the same. Now, no chemotherapy is given, especially except in patients who have got your invasive disease elsewhere, and there is no relation to OC pills use, or there is no relation to your BRCA mutations. Stick is the only lesion which is going to be related to your BRCA mutations, and that lesion is a pre-invasive lesion which will again go on and develop into an ovarian carcinoma. One more thing that you have to remember is borderline ovarian tumors do recur, and at the time of recurrence, 30% of them will be actually an invasive ovarian cancer. So they are having a propensity for recurrences, and when they do recur, about 30% of them will recur as an invasive ovarian cancer. So these are some points that you need to remember as far as the borderline ovarian cancers are concerned. You will find that borderline ovarian cancers are something which are very commonly asked. Some question or the other will come up in either your NEET or your AIIMS from these areas. So next question is, when you have ovarian carcinomas, which factor is not protective in your ovarian carcinoma? Which factor is not protective in your ovarian carcinoma? Is it nulliparity, 5 years of OCP use, breastfeeding, or tubal ligation? So what do you think is a factor which is not protective? Which factor is not protective? So yeah, most of you seem to have gotten it right. It is nulliparity. So nulliparity is something which is generally not considered to be a protective thing. Multiparous women are found to be much better protected. So what about the rest of the things? When you take up, nulliparity is the answer. So there are some strong protective factors and there are some weak protective factors. If you take up the strong protective factors, we have salpingo-oophorectomy, which is probably the strongest protective factor, and that is why we do a risk-reducing salpingo-oophorectomy in patients who have a BRCA mutation, which is highly protective against ovarian carcinoma. So what proportion of ovarian cancer is prevented when you do a risk-reducing salpingo-oophorectomy in a patient with a BRCA mutation? What percentage of ovarian cancers are protected? Yes, so the answer is somewhere around 90 to 95%. You will have protection against ovarian cancer. So what happens to the rest of the 5%? Why does this 5% of ovarian carcinomas happen? From where does it usually start? Yes, so it starts as something called as a primary peritoneal serous carcinoma. So even though you're removing the ovary, the entire pelvic epithelium, the entire pelvic peritoneum is going to be one of the areas which is going to be at risk when you are going to go ahead and do a risk-reducing salpingo-oophorectomy. So in view of this, about 5 to 10% of patients can still come back with a invasive malignancy, which is usually a primary peritoneal serous carcinoma. So the strong protective factors as far as your ovarian cancers are concerned are salpingo-oophorectomy, OC pills use, and your high parity. The weak protective factors are going to be tubal ligation and hysterectomy. Other than this, lactation and incomplete pregnancies are also considered to be something which are weak protective factors. So you have the strong factors and the weak factors. The strong factors are the OCP use, high parity, and your salpingo-oophorectomy. The weak factors are going to be your lactation, incomplete pregnancies, tubal ligation, and your hysterectomies. If you take up your hysterectomy is protective, as just I was about to answer that question. Hysterectomy and your tubal ligation, both of them, they interfere with the blood supply to the ovaries. So the ovarian blood supply is derived from multiple areas. So when you remove the uterus, the uterine component of the blood supply is going to be taken off. The anastomosis in that area are going to be taken down when you're doing a hysterectomy without doing the salpingo-oophorectomy. So that is why your hysterectomy is protective, and the same thing applies for tubal ligation as well, because you are interrupting the blood supply. Incomplete pregnancies and your lactation are going to be some things which are going to be not very effective, because they do not give the complete protection as what you have at the time of pregnancy, but they are also the weak protective factors which are available for you in the prevention of your ovarian cancer. So risk factors for endometrial cancer in postmenopausal women are all except anovulation, smoking, obesities, and sequential OCPs. So which do you think is not a risk factor? Okay, so most people seem to have gotten this right. This is one thing that you may remember. Now, smoking is associated with a number of cancers, but it is found that as far as endometrial cancer is concerned, smoking is kind of like a protective thing. Okay, so smoking is considered to be a protective factor as far as your endometrial cancer is concerned. There are multiple theories which are there for that, but smoking in general is something which is a protective factor as far as endometrial cancer is concerned. But when you look at the other things like anovulation, your obesity, sequential use of OC pills, all of these are going to be definitive risk factors. When you take up OC pills, on the other hand, when you have the combined oral contraceptive pills which have progesterone, they are considered to be protective. When you use only the estrogen pills, or when you are using the sequential pills where you will initially use the estrogen component and then switch over to the progesterone component, that kind of thing, when you have, you will have an increased risk, whereas your combined oral contraceptive cells are going to be protective. Can you tell me one other risk factor which is something similar to this, where something in one area of life is going to be protective, in other area of life it is going to be something that causes a cancer? Parity, tamoxifen. Yes, tamoxifen is a very good example, Yogesh. You are right. When you have tamoxifen, that is something that can prevent a breast cancer, but it is something that can induce a uterine cancer. Anything else? Yes, I was actually looking for this particular answer. You're right, absolutely, Varun. So obesity, premenopausal and postmenopausal. So postmenopausal obesity is something which is a risk factor for breast cancer. On the other hand, premenopausal obesity is a protective factor. So this is something which many people may not know. Premenopausal obesity is a protective factor against breast cancer. On the other hand, postmenopausal obesity, which is there, is going to be a risk factor for development of your breast cancers. So something similar to that. Here also we have smoking, which is going to be a factor which is not which is actually inversely related to the development of endometrial carcinoma. So endometrial carcinoma type 1, which gene is not involved? So most of you seem to have gotten this right. So here you are all right. So P53 is the gene which is not implicated in the causation of your type 1 endometrial cancer. So where is P53 implicated as far as endometrial cancer is concerned? It is implicated in the type 2 of endometrial cancer. So type 1 endometrial carcinoma, classically, those are the ones which are associated with your hormonal use, early menarche, late menopause, OC pills use, low parity, nulliparity. All these are going to be some of the hormonal risk factors. So that is usually the low grade type of endometrioid carcinomas. So here the most commonly mutated gene is going to be your P10 mutation. So P10 mutation is going to be the one where you will get a classical type 1 endometrioid carcinoma. Other than that, KRAS, beta catenin, ARID1A, all these are the other mutations that can be found. Type 2 is a high-grade carcinoma, which is usually not related to your hormone exposure. And this one has got the characteristic P53 mutation. And along with that, you will also find that there is going to be amplification of HER2 and loss of the ERPR and loss of E-cadherin as well. So these are the characteristic features of your high-grade type of endometrial carcinoma. So can someone tell me currently, if they ask you the question, I have not given you the choices. These 4 choices are not mentioned. I am talking about the molecular subtypes. Which molecular subtype of endometrial cancer has got the best prognosis? That is something that will come up in your examinations. Yes, Varun is way ahead of the curve as usual. Chandana is also right. So it is the pole mutation. Okay, the polymerase E gene mutation that you find, the polymerase E mutated cells that you're going to type, that molecular subtype, the pole E mutation type, that is the one which is going to be important as far, which is going to have the best prognosis. Just like you talk about the luminal A, so in your endometrial cancer, you remember that it is going to be the pole which has got the best prognosis. So can someone tell me what is going to be the worst prognosis type as far as endometrial cancer is concerned? Copy number high, correct. So here again, you will have the copy number high. So essentially what you mean by copy number high is usually you will have the P53, which is going to be high as far as this molecular type of endometrial cancer is going to be concerned. So you have your pole mutated type, then you have your MSI type, then you have your copy number low, and then you got your copy number high. So the best prognosis is the pole mutated type, and the copy number high with the P53 is going to be the worst prognosis. They do not always correspond to the type 1 and the type 2 cancers. That is also something that you need to remember. The type 1 and type 2 cancers are not directly related. Like, it's not mean that pole is always a type 1 cancer. No, it does not mean like that, because some variety of high grade cancers also are possible in pole. But in general, the pole subtype has got the best prognosis among the molecular subtypes of your endometrial carcinoma. So what is common in cervix, vagina, vulvar carcinomas? Which infection is common? This is, I think, a straightforward answer that most of you will be aware of. It is, HPV. So which subtype and what is the, number of, HPV that is going to be, the percentage of HPV is going to be the one which is important. So what is the HPV percentage in cervical cancers? Okay, so the correct answer that we are looking for here is, in patients with cervical cancer, you find that it is almost 99% related to your HPV. So HPV is an essential factor. So HPV 16 and 18, if you ask separately, that is found in 70% of cancers, 70% of CA cervix. On the other hand, as a whole, if you look at it, CA cervix, if you look at it, that number is going to be 99%. So the answer is, what I'm looking for is 99% of all CA cervix is going to be related to your HPV. Okay. On the other hand, if you take up the other subtypes, you will find that with your type 2 carcinoma of the vulva, that may be again one question that may come for you. So which type of carcinoma of the vulva is going to be implicated in the HPV subtype? So this is going to be your type 2 carcinoma of the vulva. So here you will find it is younger age group, P53 negative and P16 positive. So that is again an MCQ that may come for you guys. So these will be P16 positive and P53 negative. That is the classical subtype, type 2 carcinoma of the vulva. And usually they will be basaloid in type, and they will have little or no keratin formation. These are the classical type. So in your, okay, the next question that someone has asked here is, what is the percentage in oropharyngeal SCC? The oropharyngeal SCC, the percentage is kind of like, variable. What we have here is multiple sources. If you look at it, they give a quotage of around, 80%, 70%, multiple things are there. But in the Western population, it is somewhere close to 85% is oropharyngeal HCC is related to your HPV. And again, you will find that HPV 16 is responsible for 90% of all cases. So 90% of all cases is going to be related to your HPV 16. So 80 to 85%, as I said, is going to be the percentage which is related to your oropharyngeal squamous cell carcinomas. And if you take up the carcinoma of the vulva, it is somewhere around 50%, 60%, various numbers are quoted. And here in carcinoma of the vagina, if you look at it, it is around 60 to 70% are associated with an HPV infection. So all of these are associated with HPV. Okay, so that is going to be the key factor that you need to remember here. So all these are going to be related to your HPV infection in various proportions. Anti-rank ligand DENOSUMAB is used in which type of bony sarcoma or bony tumor? So is it going to be AIIMS? Is it osteosarcoma? Is it chondrosarcoma? Is it giant cell tumor? Which one is the right answer? Okay, so most people have seemed to have gotten this right. So the answer is clear cut. It is the germ cell tumor. Sorry, it is the giant cell tumor. Okay, so when you have the giant cell tumor, which is a benign tumor, it is not a malignant tumor. So a benign tumor of the bone is your giant cell tumor, but it can undergo rarely a malignant transformation. So giant cell tumor of the bone will have a characteristic what appearance on X-ray? What is the characteristic appearance on X-ray on radiographs for giant cell tumors? Yes, so soap bubble appearance is there, which is going to be characteristic in your giant cell tumors. So what is there for your osteosarcoma? For GCT, as it is already mentioned, it is a soap bubble appearance that you will have. So what will happen in your, in your osteosarcoma, if you take it, it is going to be characteristically what we call as the sun ray or the sunburst appearance of periosteal reaction that you're going to have. So that is going to be the sunburst calcification or the sun ray appearance. As someone has mentioned, the Codman's triangle, all these can be found. So can a Codman's triangle be found in an Ewing sarcoma? Yes. So what you have to remember is Codman's triangle is not specific to your osteosarcoma. You need to have the bony matrix producing cells, the osteoid being produced by the malignant cells, that is going to be showing the that the tumor is going to be your osteosarcoma. And what is going to be the characteristic in Ewing sarcoma? All of you will know that. So that is going to be your onion skin appearance or your onion peel appearance. So this is all the presentation that you will get in your Ewing sarcoma, osteosarcoma, and your giant cell tumor. So this is something which they may ask you as an X-ray as well. I will probably put it up. I don't have the picture here with me. So these are the things that you need to remember as far as the various subtypes of bony tumors are concerned. As far as the management is concerned, your anti-rank ligand DENOSUMAB is going to be something which is going to be used in your giant cell tumor of the bone. So where will you use it? In unresectable or metastatic diffuse giant cell tumor, the preferred management is DENOSUMAB. That is the category 1 management. So it's a category 1 management, category 1 reference as far as your NCCN is concerned for the management of your giant cell tumor of the bone. And the other thing that can be used in this kind of a scenario is also radiation, but radiation is associated with a higher risk of malignant transformation, and that is the reason why we do not use radiation for giant cell tumors. Preferably, we go for a rank ligand inhibiting monoclonal antibody, which is going to be DENOSUMAB. The other thing that can be used is your interferon alpha 2b. Both of these can be used. Okay, so that is going to be the answer for this particular question. Right, a 70-year-old male with a fracture of the neck of the femur, calcium is low, alkaline phosphatase is high, phosphate levels are normal. What is the diagnosis here? Now, this question actually generated a lot of answers. Okay, this question actually basically generated a lot of questions for me as well. I am not sure of the answer. Let me say and put it as what I have put as the answer and why I arrived at that answer. Okay, so the answer that I arrived at was at osteoporosis. If you look at it, you've got osteomalacia and Perthes disease. These are the two things that can be definitely ruled out in this kind of a scenario. So why can we say that it is not osteomalacia or Perthes disease? How can we say that? Because Perthes disease is something that happens in young age and in adolescence. It's around 5 to 15 years. Yeah, it is something that happens in the pediatric age group. So again, you find that in your osteomalacia, you will have a low calcium. In osteoporosis, the calcium is going to be low or normal. Both can be there. And in metastasis, again, you will find that the calcium is high. So that is why we have two possible answers for this question. It is one going to be osteoporosis or it is going to be metastasis. In metastasis, it is very unusual to find the low calcium again. You will usually get a hypercalcemia. In carcinomas, generally, if you look at it, you have two type of hypercalcemia that can come. So that is the reason why I have said that this could be one osteoporosis. That is what I think is the answer. It still could be metastasis. Okay. So normal phosphate levels, that rules out an osteomalacia, because in osteomalacia, you will have a low phosphate and a low calcium. Both will be low because of the altered vitamin D metabolism. Perthes disease, as everyone knows, happens in the pediatric age group. The calcium levels are the ones which may or may not be low or normal. That is what is mentioned for osteoporosis. And metastasis, it can be low, normal, or high. All three can be there. But in general, whenever you have a fracture level of osteoporosis, fracture level of metastasis, more often than not, you will find that the calcium is going to be high. It cannot be low when you have a metastasis. So that is the reason why I thought that we will mark the option as osteoporosis. It may still be metastasis. So I will just say that this is a diagnosis of detection where I have made it here. I think the most probable choice is going to be your osteoporosis. The secondary answer could also be a metastasis, because as someone already pointed out, in your osteoporosis, more often than not, you will find that the calcium is going to be normal or low. Both are possible in that. In metastasis, again, you can have a low calcium or a normal calcium, or you can have high calcium. But in general, with bony tumors and other such things, when you have either metastasis or a primary bone resorbing tumor which is going to be present, then you will find that the calcium levels are going to be high. And that is the reason why I was thinking more in terms of osteoporosis as an answer and not the other one. Next question. Isolated limb perfusion in soft tissue sarcoma. What is the false statement? If you look at this, the answer is B. So what is the answer for this one? Real-time drug assay to monitor the drug leak. What is wrong with that? What is wrong with that? Most of you have gotten the answer right. So that is true. But what is wrong with the statement? That is a false statement. But what is wrong with that statement then? Use of gamma camera. Okay, but that can be again a real-time thing. But I will put it like that. See, ILP in your soft tissue sarcoma, it uses melphalan and TNF alpha. This is the characteristically used scenario now. In soft tissue sarcomas, which are considered to be unresectable or borderline resectable, here you will use your isolated limb perfusion. There are some things that are associated with your isolated limb perfusion. One is going to be, it is a surgical procedure where the vessels are exposed by directly dissecting in that particular area. You have to know some of the differences between your isolated limb perfusion and your isolated limb infusion. Two are similar techniques. When you talk about ILP or perfusion, when you're talking about perfusion, you are going to surgically isolate the vessels. So surgical isolation of the vessels is going to be done, and here you always have a hyperthermia which is going to be there, and it is going to be isolated from the rest of the system. In the other hand, when you talk about isolated limb infusion, this is done by means of radiological technique by using catheters. So that is how you will do as a different thing. And again, total isolation is usually done in your isolated limb perfusion using a heart lung machine. Isolated limb infusion, on the other hand, it is going to be done through catheters, and the total isolation may not be there. There is going to be a higher proportion of leak that is going to happen. So this can cause severe skin and soft tissue necrosis. The significant or the highest grade, this grading system has got a name that is known as the Weiberding toxicity scale. So this may be one MCQ that may be asked, because ILI, ILP are some recent technologies, not really recent, but they are, some name technologies which, examiners are fond of asking questions from them. So when you take up ILP, the Weiberding scale, that is the one which is going to be used to measure. So stage, you've got a grade 1 to 5 in that. The grade 5 is the one which needs an amputation, and grade 1 is going to be just some mild erythema which is going to be there. So from erythema till amputation, you have all the grades in your Weiberding toxicity scale. So arterial and venous cannulation, hyperthermic infusion is done between 41 to 43 degrees. And what you generally do is the leak testing is done before starting the drug. So real-time monitoring is not commonly done. It is being done in certain select scenarios now. Real-time monitoring is done, but standard of care, if you look at it, isolated limb perfusion, you do not have a real-time monitoring of the drug assay. You will isolate the system surgically. You will, as someone had put it up, measure it by using your gamma camera. You will find out whether there is any significant leak. And then after that, you will go ahead and you will start the drug. It is possible, Varun. It is not that it is not possible. It is possible, but it is not widely used in many scenarios. So what we generally have is, this is a system where we isolate the particular artery and the limb that goes there. At various levels, it can be done. So you can do it at the high thigh level. You can do it at the thigh level. That is, you can do it at the iliac level. You can do it at the, at the level of the common iliac, at the level of the iliacs, and then you can do it at the level of femoral and the popliteal. 4 levels are possible as far as the lower limb is going to be concerned. So when you're doing it, you will isolate the vessels completely. You will check for the leak. Then you will establish your hyperthermia, and then you will start the drug infusion. So real-time monitoring is not a classical thing that you do when you are doing your isolated limb perfusion. So next question is synovial sarcoma in the medial aspect of the right forearm without neurovascular bundle involvement with a solitary peripheral resectable pulmonary metastasis. What is going to be the management for this particular presentation? So this is a classical question. This is the kind of scenario also that you will get in your clinics as well. So is it going to be surgery followed by radiation and chemotherapy? Is it radiation followed by surgery and chemotherapy? Is it chemotherapy followed by surgery and radiation? Or is it palliative chemotherapy? Clearly, we are looking at a M1 disease. Okay, so what is going to be the option? Okay, most of you are going to choose C as the option. Anyone else has anything different? Yes, Varun actually got it right. The answer that I am looking for is surgery followed by radiation and chemotherapy. That is the answer that I am looking for. Subhajit, you are also right. Now let us get into the idea behind why we choose that particular option. Okay. So now whenever you have STS of the extremities that is resectable without major morbidity, the management is predominantly by surgery and then by radiation. Now this sequence of radiation versus surgery is something which is not very definitively established as far as your soft tissue sarcomas are concerned. Many centers, they are actually preferring neoadjuvant radiation because preoperative RT has some benefit in terms of wound, in terms of your, the volume of radiation which is involved and with regard to the long-term side effects. So because of this, some centers go for a preoperative RT, but then the classical treatment will be your resection of the primary when it can be done without any major morbidity. Now here you can say it is there in the medial aspect of the right forearm. without a neurovascular bundle involvement, which makes it a clearly resectable primary disease. Now let us look at the metastasis. So there is a solitary peripheral resectable pulmonary metastasis. Here again, whenever you have limited metastasis, the management is primarily resection followed by your chemotherapy. Okay, so especially when you have lung metastasis in your osteosarcoma or in your, especially with your soft tissue sarcomas, even in osteosarcomas, generally we'll go for an upfront chemotherapy. So when you take up especially soft tissue sarcomas, whenever you have a resectable primary and a resectable lung metastasis, the management is initially surgery and later on you will go for chemotherapy. So here actually you can have both A and B, both of these can be choices, but traditionally speaking, you will go for surgery followed by radiation, and then you will go for the chemotherapy, which is going to be the best possible option for this particular scenario. Most other places, you will start off by giving chemotherapy. Okay, most other scenarios, any other solid organs when you have, you will be considering going in for chemotherapy first, and then you will be dealing with the rest of the, either the primary or the metastasis. But in case of soft tissue sarcomas, where you have a resectable primary and a resectable metastasis without too much morbidity, in such scenarios, you will go for surgery, then radiation and chemotherapy. That is going to be the ideal way to manage these tumors, right? Lymph node metastasis during initial presentation of sarcoma, what is the likely histology? This is a clear-cut question. Most of you will know the answer. Let's give it a minute for the others to answer as well. So the answers are starting to come in. Most of you have gotten it right. So it is B. This is a clear-cut case where angiosarcoma is the answer that we are looking for. So there are 5 malignancies, the soft tissue sarcomas. You can have the, what you can say is that it is known as races. So when you have races, so what do you mean by races? This is rhabdomyosarcoma, especially the embryonal variant of your rhabdomyosarcoma. Then you have your angiosarcoma, clear cell sarcoma, epithelioid sarcoma, and your small cell sarcoma. What is actually small cell sarcoma? It is the desmoplastic small round cell tumor. Now, this is something which has been there for a long time. This races is something which you have been learning for a long time. But as I said, whenever you prepare something for presenting to you guys, especially when you need references, that is where the difficulty comes. So I was able to find it in this article in European Journal of Surgical Oncology. We find that this is clearly mentioned that these are the metastasis. These are the sarcomas that commonly present with metastasis. There are also other tumors which are mentioned, but in general, these are the ones that are commonly found with metastasis. The acronym is going to be your RACES, which is going to be embryonal variant of your rhabdomyosarcoma, angiosarcoma, clear cell sarcoma, epithelioid sarcoma, and your small cell sarcoma, which is the other name for your desmoplastic small round cell tumor. So these are the common ones which are going to be associated with your lymphatic metastasis, lymph nodal metastasis, right? So preoperative versus postoperative radiation in soft tissue sarcoma, which is the false statement. Increased effect as oxygen and vascularity is maintained. Early wound complications are increased. Late wound complications are reduced. Increased dose as the tumor is intact. So which is the false statement here? Okay, so most people have gotten it right. I was just discussing it in the previous question, a couple of questions back. So it is right. So the advantage of giving preoperative radiation is generally when you have the tumor in place, it is easier to define the margins. So the volume of radiation which is used for that particular patient is going to be less wherever you're going to use a preoperative radiation. So pre-op RT, you will not have an increased dose, you will have a decreased dose of radiation, and that is why that is the option that you are looking for here. So the option here is there is no increased dose, there is going to be a decreased dose. So what happens when you have radiation being given with the tumor in place and without surgery? So without surgery, there is no fibrosis. There is going to be increased vascularity, and because of this, an increased oxygen is going to be given to that area, and oxygen levels are going to be normal. That facilitates your effect of radiation. The formation of the reactive oxygen species is going to be there. So that is why this is going to help. Then you have your early wound complications which do increase. So the wound healing problems usually happen when you give your preoperative or your neoadjuvant radiation. On the other hand, the late wound complications like your formation of fibrosis, formation of contractures, all this is found to be less when you're going to give your preoperative RT vis-a-vis your postoperative adjuvant radiation. So adjuvant radiation will have an increased risk of late wound complication, and the dose which is going to be used is going to be reduced. So preoperative RT is used, sometimes it is being advocated by some specific people because of the smaller volumes, lower radiation dose, early wound healing problems are there, but late complications are going to be reduced. So that is the advantage of using your preoperative radiation, right? So left lung lesion, which is infiltrating into the first rib and the brachial plexus, suggestive of a Pancoast syndrome. What is going to be the management for this particular patient? Is it palliative chemotherapy? Is it definitive chemoradiation only? Preoperative chemoradiation followed by surgery, or is it en bloc surgery followed by concurrent chemoradiation? Okay, so most of you have gotten this right. The answer is going to be a preoperative concurrent chemoradiation followed by surgery. Now, lung cancers are something where the management can be a little confusing for many of you people. Most of you will not come across it. So I've just put it in a succinct form here. So Pancoast tumor, otherwise known as the superior sulcus tumor. This is a tumor that may involve the chest wall, the ribs, the vertebra, the parietal pleura, the brachial plexus, the stellate ganglion, or the great vessels. Now, when you have involvement in something which is resectable without a major morbidity, like when you have isolated chest wall or ribs or the parietal pleura or the parietal pericardium, sometimes when it is involved, usually the superior sulcus will not get the parietal pericardium, but any of the other three is going to be there, like ribs or chest wall or the parietal pleura alone, that makes it as a T3 lesion. So T3 is the other way to remember is it is a stage of 3Ps. Okay, the parietal pleura, the parietal pericardium, and the phrenic nerve. These three invasion, when it is found, it is going to be called as a T3 lesion. In staging also, it is asked for you time and again. So the nerve involvement, when you have the parietal pleura, the pericardial involvement, parietal pericardial involvement, or the phrenic nerve involvement, if it is going to be there, that is going to be a T3 tumor. Any other thing which is involved, then it is going to be known as, which includes the brachial plexus, that makes it a T4 tumor. So when you have T3 with N0 or N1, that is the scenario where you can manage it by an upfront surgery. Selectively, you can do upfront surgery when you have T3 with N0 or with N1 status. So when you have N2 disease, so essentially what you mean by N1, N2 and N3 disease, that is something that you have to know as far as the lung cancers are concerned. So when you take up the N1 disease, it is going to be the nodes less than hilar. So just remember like that. So the segmental, subsegmental, bronchial nodes, all this when you are having, so that is going to be your nodes which are going to be known as the N1 level of nodes. The N2 nodes are going to be the hilar nodes, which can be ipsilateral or contralateral. No, not contralateral, it's going to be the ipsilateral hilar nodes, which will come under the N2 disease. And N3 is going to be any contralateral nodes, or it is going to be your supraclavicular nodes. So any contralateral node or the presence of supraclavicular nodes, both of which will come under the N3 level of nodes. So when you have patients who have got a contralateral hilar node or patients who have got a hilar node in general, so these are clear indications. So in short, whenever the mediastinum is involved, just remember like that, whatever is there within the lungs. So within the lungs means the lobar, the segmental, the subsegmental, all these nodes when you are having. So these nodal stations are considered to be N1 nodal stations. So when these nodal stations are there, it doesn't matter. You can still go ahead and you can, treat the patient by upfront surgery. On the other hand, when you have an N2 disease, which means when the hilar nodes are going to be definitively involved, or by doing a preoperative mediastinoscopy, you detect that the N2 nodal disease is there, then you have to go for always a concurrent chemoradiation followed by surgery. It cannot be a primary surgery in this kind of a scenario. Okay, so whenever you have a N2 disease, then the treatment straight away goes into concurrent chemoradiation and then followed by surgery if it is going to be resectable, or if it is unresectable, then you will go for only palliative chemotherapy alone. Okay, so that is going to be the option. Clear now on the management of your tumors? Lung tumors, what is T3, what is T4, and how do you manage it? Because this is something that repeatedly comes up. One other question that comes up with Pancoast tumor is they may ask you the clinical presentation. They may say there is a tumor in the upper lobe of the lung, which is causing ptosis, meiosis, anhidrosis, enophthalmos. So that is going to be the characteristic presentation of your, Horner syndrome. So that is due to what? So that may be because it is involvement of the stellate ganglion. That is what they are looking for. So these are some variations of the question that may come. So whenever you got N0 or N1 disease and T3 disease, which is involvement of just the chest wall or the ribs without any of the major structures getting involved, then you can go ahead for a primary resection. Otherwise, the option is always going to be your concurrent chemo radiation, and then you will follow it up by doing your surgery if it becomes resectable. Otherwise, the patient will go in for chemotherapy. Okay, right. So the next question is T2N1 adenocarcinoma of the lung. So T2N1 adenocarcinoma of the lung with subhilar nodes. Sleeve resection is done. So what is going to be the further management? So here what we have to remember is normally we will think about, whenever there is a nodal disease, we are going to think in terms of your giving chemotherapy plus radiotherapy. In lung, it is slightly different. So when you take up the lung cancer, this is going to be the management, easy and simple way in which you can remember. So when you have a T1 or T2 with N0 tumor, so when you have early stage lung cancer, T1 or T2 with nodes being negative, then you will give only surgery as the option. Okay, only surgery is done and radiation is given only if there is margin positive tumor. Otherwise, you will not go for radiation. When you have T1, T2 with N1 disease, then you go for only adjuvant chemotherapy. So node positive needs chemotherapy. It has been found that adjuvant radiation does not improve the overall or the disease-free survival in patients who have N1 disease. So when you have N1 disease, the treatment is surgery with adjuvant chemotherapy only, and radiation as again is going to be given only for your margin positive status. Again, the same thing applies for T3N0 or T3N1 as well, where you go for surgery with adjuvant chemotherapy and radiation only for the margin positive status. And this also applies to a very select group of T4N0 as well. So where do you actually go for radiation in the adjuvant setting straight away? One we already saw was in the presence of a margin positive disease. The other one is in patients who have an N2 disease. So whenever you have your N2 disease, which is detected post-op. So how do you know it is N2, which is pre-op or post-op? So some patients, they will have staging by PET-CT, and then there is going to be no mediastinal nodes. They will undergo surgery along with the mediastinal nodal dissection. There they are found to have an N2 disease. When this is found, then you have to go for surgery, adjuvant sequential chemotherapy, and radiation. It is not concurrent chemotherapy. Here you give a sequential chemotherapy with your radiation. When you have superior sulcus tumors, usually the management is going to be concurrent chemoradiation, and then you go for surgery, and then you give your adjuvant chemotherapy. So that is the series of sequence or the sequence of how you will time your therapy. On the other hand, whenever you have a preoperatively detected N2 disease, whenever there is a preoperatively detected N2 disease, then you will have to go for definitive CTRT and then follow it up by durvalumab. What is durvalumab? Okay, so it is an anti-PD-L1 antibody, monoclonal antibody, anti-PD-L1 monoclonal antibody. This is a recent guideline that has come up. That is why I put it up here in the system that you have here. So it is an anti-PD-L1 antibody which has come up in the recent guidelines. It has become the first line treatment for cancers where you have an N2 disease and the documented N3 disease. So in essence, what you have to remember is any patient who has N2 or N3 disease will require radiation as part of his treatment. So when you have preoperative N2 disease, then you go for N2 or N3 disease, then you have to go for definitive chemo radiation. On the other hand, when it is diagnosed post-op, then it is usually going to be already have done the surgery. So then you'll have to give sequential chemotherapy radiation. On the other hand, when it is going to be only N1 disease, then there is no role for adjuvant radiation except when there is a margin positivity. So in essence, what you have to remember, my friends, is when you have an N0 disease. So when you have an N0 disease. So when you have an N0 disease, T1 or T2, in such cases, you will not go for any adjuvant therapy at all. T1, T2, N0 is going to be only surgery. On the other hand, N1 disease is an indication for adjuvant chemotherapy only. N2 disease, which is detected after surgery, you will go for sequential chemotherapy and radiation. When you have your N2 and N3 disease, which are detected preoperatively, then you will go for definitive chemoradiation followed by durvalumab. On the other hand, when you have your superior sulcus tumors, the definitive modality which you think can make it curable is going to be concurrent chemoradiation upfront, and then you can follow it up by surgery. If it becomes resectable, then go for adjuvant chemotherapy. As I already said, there are some things which are going to be slightly different in management. Now, whenever there is a contralateral single lung nodule, Now this is defined as an M1A disease, contralateral single lung nodule when it is found. If both of them are curable, then you treat it as separate primaries. See, there is no staging system in AGCC for a bilateral breast cancer. Or what you can say is what you consider, suppose there is an inner quadrant tumor and there is a second inner quadrant tumor in the opposite breast, then the previous teaching used to be you will take it as a metastatic disease. But nowadays, when you have two different sites or the contralateral side is going to get involved, then you manage it like a separate primary if it is going to be a curative scenario, if it is going to be the single site of disease. So that is something that you have to remember, friends. M1A with a contralateral lung nodule, treat it as separate primaries. M1A with a contralateral primary, you treat it as a contralateral lung nodule, you treat it as a separate primary if it is going to be curable. So this staging here it is clearly mentioned, it's a T2N1 adenocarcinoma with a subhilar node which is going to be present, and a subhilar node actually makes it a kind of disease which is going to be confined to below the level of the hilum. So that is an N1 node which is given here, and that is the reason you will go for only an adjuvant chemotherapy and no other therapy is going to be given for this patient. There is no role for radiation, right? So which is not a prognostic factor in pulmonary resection for metastasis? Is it the number of metastases? Is it going to be the previous therapy used, synchronous or metachronous nature, or is it the time since diagnosis, which is not a prognostic factor here? Okay, getting multiple answers. Yes, most of you seem to be getting it right. The answer is correct. So here what we have is, this is a correct answer. The previous therapy used will not have an impact on whether we are going to go ahead with the resection or not, and it does not have an impact on the prognosis of metastasis. Okay. If you take up patients who are being detected with a synchronous and a metachronous metastasis, so the number of metastases will make a difference. If you have got multiple metastases where it is not resectable, then it makes a difference. When you have synchronous metastasis, again, it is worse when compared to having a metachronous metastasis. And time since diagnosis, less than 3 years and more than 3 years, the disease-free interval, that makes a difference. So these are three factors that have been found to be having a prognostic significance. One is the resectability, whether all the metastases can be resected and have an adequate pulmonary function. So that is the one thing. Then whether it is solitary or multiple metastases, then a disease-free interval of less than or more than 3 years, all these are going to be factors which are going to be of prognostic significance when you're going to go for a resection of the lung metastasis. The previous therapy used does not have any influence on this. Previously extensively treated also, still if the metastasis is going to be resectable, we will plan for a resection. So synchronous metastasis, where can you plan for resection? You can plan for a resection in patients who have got colorectal cancers. So here in this scenario, you might plan for a synchronous resection of the metastasis as well. So prior therapy does not have any impact on the decision on whether we are going to go ahead and resect the tumor or not, right? So first investigation in planning for your lung resection, what is the first investigation? Is it cardiopulmonary stress test? Is it FEV1? Is it FVC? Is it FEV1 by FVC ratio? Which is the first test that will be done? Okay, again, most people seem to get this right. The answer is right. It is a FEV1, or some of you have marked it as C. So that is where the confusion will come in. Okay, so let us look at how will you evaluate a patient who is going to be planned for a pulmonary resection. It can be either a lobectomy. See, generally, whenever you're planning for a patient for surgery for a lung resection, you have to remember that this is a patient who is being planned for both a lobectomy and a pneumonectomy, because you don't know. Okay, the question someone has mentioned is most important predictor. What's the question that is asked here? Then the nature will change. But anyway, let us look at it. I will talk about the whole thing here. So when you talk about FEV1, that is going to be the first test that you're going to do. There is a sequence of events that you do when you're going to resect a pulmonary tumor. So first thing is whether it's an extremely high cardiac risk patient who has got a triple vessel disease, got a cardiac bypass, all this kind of thing. Whenever you have it, then straight away you're going to need a level 3 cardiopulmonary exercise test or a cardiopulmonary stress test. So this, if the answer is yes, then you're going to need a level 3 test. But in general, most of the average risk, unless this is given very specifically, it means it is an average risk patient. So when you have an average risk patient, so then what is the level 1 test that you will do? You will do, one is your pulmonary function test, and then you will do the diffusion capacity of your carbon monoxide. These are the level 1 tests which are going to be done. So you have a percentage of predicted level or predicted post-operative. PPO stands for predicted post-operative. So PPO stands for predicted post-operative. So this predicted post-operative levels are one of the important levels. So what are the two levels you will take it? One is the PPO levels of FEV1. The other one is going to be the PPO levels of your DLCO. So any of this, if it is going to be more than 60%, then straight away the patient is going to be fit for a lung resection. He is going to have a low risk. There is no need to do any other tests. Okay, so when you have a predicted postoperative value of either FEV1 or DLCO, which is more than 60%, then you can straight away say that the patient can undergo a lung resection. Okay, so that is the first test that you need to remember. So still, whether it is going to be the first test which is asked, or whether it is going to be the first screening test, or whether it is going to be the most important test which was there, or DLCO is an option, then it becomes more difficult. Okay, DLCO is an option, then it becomes more difficult. But even then, I will say, if you have FEV1 and DLCO, more often than not, you will find that the first test which will be done is a pulmonary function test. So I will still say, even if DLCO is given among the options, suppose let's say this FEV1 by FVC is not there, or this instead of this FVC here it is mentioned as DLCO. Let's say that here it is mentioned as DLCO. Even in that scenario, I will still go for FEV1 as the option. Why? Because the first test which will be still done is still going to be only a pulmonary function test, where you will look at the predicted postoperative value of your FEV1. So how do you predict the FEV1 values? You measure the FEV1 and then you take it and divide it by the number of segments which are going to be removed for a lobectomy, and based on that, or a pneumonectomy. And then if that value is more than 60%, then the patient is going to be fit for a lung resection. And the same values apply when you're doing the DLCO test as well. So when it is going to be less than 30% on the other hand, that is when you will do the cardiopulmonary exercise testing. And if you do a cardiopulmonary exercise testing and then he is found to be fit, still you will do it as a high risk procedures, but you will try to do for a limited resection or the non-operative treatment modalities. On the other hand, if the value is between 30 and 60%, so this is where you will do the stair climbing test or the test of walking between the two markers. So these two tests are going to be done, which will determine whether the patient is going to be eligible for undergoing a test. So stair climbing more than 20 meters and your walking test, which is going to be more than 400, which is given in some things, and more than 250, which is given in some textbooks. So when you have a value which is going to be more than 400 or more than 20 meters or 22 meters, then the patient is going to be eligible. So shuttle walk test, what does it essentially mean is, you will have two markers which will be placed, okay, some distance apart, and then you will measure it. And between the two markers, the patient is going to shuttle back and forth. So that is why it is called as a shuttle walk test. So between the two markers, the patient will shuttle back and forth. Here, ideally, he needs to go for around 400 meters. Okay. So ideally, the patient needs to go for 400 meters. So in your shuttle walk test, the answer is roughly 400 meters, but less than 250 meters if the patient is going to walk, then that is going to be a high risk. So when the value is going to be less than 250, or the value is going to be less than 20 meters or 22 meters in your stair climbing test. So it depends on the number of stairs which are going to be there. So if you have a value of less than 20 meters, in such scenarios, you will have to plan for a high level testing, or the next level testing, which is going to be your cardiopulmonary exercise testing. Okay, so simple scenario, my friends. The first test you will do is going to be your pulmonary function test. In that particularly, you're looking at your FEV1 levels. Okay, the other test which will be done for screening along with it is going to be your diffusion capacity of your carbon monoxide. So if both are given, then you will have to probably go, if the answer is given as first, here the question of playing around with words will come a little here. Okay, so when you have the option as which is going to be the first test, okay, suppose they ask you which is going to be the first test which is going to be done, then you have to choose the option as either PFT or is going to be FEV1. If the option is going to be given as screening test, again the option is going to be something similar. For screening, again we are likely to use an FEV1. On the other hand, which is the best screening test if they have given, then probably I will choose DLCO as the option, because Compared to FEV1, which depends on how the patient actually performs the test, it can vary. The result can vary. On the other hand, when you have this particular kind of thing where you have a defined value which can be easily done, that observer variability or that patient variability is not going to be there for your DLCO. So that is the reason why your DLCO is preferred as the best modality. But the first or the screening modality, if the question comes, then the option is going to be your FEV1. Are you guys clear on this? Because multiple times these questions have been asked at various levels. So just remember this both in your practice and here also it is important. So pulmonary function test, FEV1, that is going to be important. And the next step which is going to be done once you have done this first level of test is going to be your stair climbing test and your shuttle walk test when the value is between 30 and 60%. Less than 30%, you have to do the level 3 test, and only then you have to proceed with the rest of the surgical excision after getting the clearance. Okay, so this is how you will proceed with the patient who is being planned for a pulmonary resection. So anti-CTLA4 drug. So this one is a very clear-cut answer. All of you will know the answer. It is a ipilimumab. That is going to be the drug which is known as an anti-CTLA4 agent. It was the first immunotherapy agent which was approved for use. It was the first immunotherapy agent which was approved for use in malignancies. In that, in melanomas, it was first started. So what you do, it is an anti-CTLA4 antibody. It comes under the group of something known as the checkpoint inhibitors. It is approved in melanoma. Now what you have are the other checkpoint inhibitors, which include your pembrolizumab and nivolumab, which are going to be your anti-PD1. Note this, my friends. This is again a question that has come multiple times. It is anti-PD1. There is another recent drug which is there, which is known as semiplimab. Okay, semiplimab, which is also the first drug which is approved for your cutaneous metastatic squamous cell carcinoma. For your skin cancers, this semiplimab is the drug which is an anti-PD1 agent which has been approved in the management of cutaneous advanced squamous cell carcinomas. The other drugs which are anti-PD-L1. So PD1 and PD-L1 stands for, L stands for ligand. Just we saw like the rank ligand blocker. So that may be one question, whether it's a rank blocker or a rank ligand blocker. So it's a rank ligand blocker that you have in your DENOSUMAB. So the same way here also, avelumab, atezolizumab and durvalumab, which we saw as the drug of choice in lung cancer, we have anti-PD-L1 agents. Now what you have to remember is, for your urothelial malignancies, all the checkpoint inhibitors have been approved. Okay, for all the urothelial cancers, the transitional cell type of cancers, all the markers, all the agents have been approved. All the agents which I mean are the pembrolizumab, nivolumab, avelumab, durvalumab and your atezolizumab. All these 5 agents are approved in one cancer, and that particular cancer is your urothelial cancer. When you take up Merkel cell carcinoma, there the one drug which has been approved is going to be your avelumab. So that may be a question that may be asked for you. So in your Merkel cell cancer, if you look at it, the drug which has been approved is going to be your avelumab. The next question is, they may ask you about the anti-PD1 and the anti-PD-L1. There also, do not make a mistake. Clearly note, pembrolizumab and nivolumab are the anti-PD1 agents. Just remember that, along with semiplimab, which has come up recently. Okay, so these are some of the drugs. All these drugs together are known as the checkpoint inhibitors. Okay, so they are drugs which are currently the craze as far as medical oncology is concerned. Any malignancy you take, you cannot go ahead without knowing about these particular group of drugs. Right. The FDA approved drug for germline BRCA mutation is what? Is it PARP inhibitors? Is it CDK inhibitors? Is it MEK inhibitors? Is it the HDAC inhibitors? This one is again a clear-cut question. All of you will know the answer. That is the PARP inhibitors. So PARP inhibitors are olaparib, niraparib and rucaparib. They are approved for use in germline mutations or somatic mutations. So that may be one question. They are used in both germline and in somatic BRCA mutation. Now, can someone tell me what is the difference between a germline mutation and a somatic mutation in BRCA? What is germline? What is somatic? Someone will put it up here, the chat box. What is a germline mutation? What do you mean by a germline mutation? And what do you mean by a somatic mutation? Yes, so basically that is the way to look at it. Germline is present in the initial, whenever the fertilization takes place, it is transmitted from one generation to another. So the germline mutation cells are present at the time where it is transmitted from either the mother or the father, and it is present at the time where the fertilization takes place and then the organism is going to develop. So that is known as a germline mutation. On the other hand, your somatic mutations are the ones that happen de novo. A patient is there, he develops an a new mutation due to some environmental change. So that is a somatic mutation. So germline mutations, as everyone has put here, is something that is going to be present in every cell. On the other hand, when you're going to test your tumor cells alone and only they have the mutation, that is known as a somatic mutation. So basically what you will do is you will submit the tumor cells for your mutation and you will submit the body cells. Like you can just draw a blood sample and submit it. Previously it used to be the buccal mucosal sample. Nowadays we just do the blood samples. So these mutations are detected on that. So if it is found in both the samples, then it is a germline mutation. In a sense, it is going to be, suppose you do for the tumor, it can be a germline, it can be a somatic, you don't know. On the other hand, when you do it in the buccal sample or you do it in the blood sample and you find it, then you know clearly it's a germline mutation. So where is it approved? PARP inhibitors are approved in somatic or germline mutated ovarian carcinomas as maintenance therapy. This is again a new thing that has come up, maintenance therapy. So maintenance therapy in ovarian cancers. So that is where you have the application of your PARP inhibitors. Select breast cancers also you have indication for using these PARP inhibitors where you're using it in conjunction, especially with your letrozole, with exemestane, all these drugs, it is being used more and more nowadays. But the classical use is in ovarian cancer. It can be used in recurrence. It can be used in primary maintenance therapy. All these sequences, everywhere it is used now. It has been approved for maintenance as well, not just in the recurrence setting. It has been approved even in the maintenance therapy as well. Last year, a question had come from this group, CDK inhibitors, which put it as PLABO, it is palbociclib. So palbociclib, ribociclib, and abemaciclib. These are the three drugs which are going to be your cyclin inhibitors or cyclin dependent kinase inhibitors. That is the reason why you have this cyclin inhibitor in the name itself. And here again, the clue is there here. PAR stands for PAR and IB stands for inhibitors. As we already know, all the small molecule tyrosine kinase inhibitors are going to be named with the suffix of IB. And again, the structure which is going to be labeled before that will give a clue as to the type of inhibitor that we are going to be talking about. Like for example, here we have the RAF inhibitors which are going to be known as RAF inhibs. So you have dabrafenib, remurafenib. So all these are going to be there. Then you have your trametinib, which is going to be an MEK inhibitor. Trametinib is going to be an MEK inhibitor. And then you have your selumetinib. This drug is something which is going to be used in a special scenario of differentiated carcinomas, which is known as redifferentiation. What it essentially means is when you have cells, thyroid cancer, when you have differentiated thyroid cancer where you have radioactive iodine refractory, when it has become radioactive iodine refractory, you will give the selumetinib drug, or that is, that drug when you give, you find that this converts the radioactive iodine refractory agents into a radioactive iodine susceptible agent. So you can go back and do the radioactive iodine therapy. So radioactive iodine refractory drugs. So in that kind of a scenario, you will use this selumetinib. That is one of the other drugs which can be used. So these are the various types of inhibitors. I've just taken the chance to put it up here because these are questions that are asked repeatedly. Something from medical oncology, especially with the latest drugs, is almost a given in any exam that you attend. Right. So this is again one of the questions. Yesterday also we had a discussion about antibody drug conjugate. So here, which is the false statement about antibody drug conjugate, which is given here. Okay. So brentuximab vedotin is an example of an ADC. It's used in normal cells and to deliver, it's used to spare the normal cells and deliver chemo to the malignant cells. And then you have a decrease in specificity. So this one is actually a pretty easy question among all the questions that you had here. This was the easy question because whenever you have any kind of targeted therapy, it is going to increase the specificity. It need not decrease the specificity. It will increase the specificity. So that is why this is the wrong choice. It does not decrease. It increases the specificity towards the target. Classical ones is TDM1. We already talked about that along with the other drugs which were given in, which are going to be used in your as antibody drug conjugates. So they are basically conjugates of chemotherapy drugs with your monoclonal antibodies. You have radio conjugates also which are available where you combine a radioactive pharmaceutical with your this one. So the characteristic, TDM1 and the brentuximab vedotin are going to be the drugs which are going to be used in your various conditions. In this, they are likely to be asking about TDM1. So sensory neuropathy is seen in which particular chemotherapy drug? This is again a sitter. This is a very easy question for most of you to answer. Oh, even there I find some variation in answers. Okay, A, B, C. Okay, the answer, I thought this was something which all of you would have gotten. Many of you seem to be getting right. It is paclitaxel. So peripheral neuropathy is going to be the dose limiting toxicity. Okay, peripheral neuropathy is going to be the dose limiting toxicity of paclitaxel. It is characterized by the glove and stocking neuropathy, what we call as the glove and stocking sensation, which is going to be the dose limiting toxicity of paclitaxel. On the other hand, when you take up capecitabine and your 5FU, you have something called as a HFS or the hand syndrome. What you mean by the hand-foot syndrome is basically there will be erythema and kind of itching which is present in the hand, erythema, desquamation kind of thing which happens. So this happens with both your capecitabine and with your infusional 5FU. Now capecitabine is a pro-drug. So capecitabine is a pro-drug of your 5-fluorouracil. So capecitabine and infusion 5FU, both of them will cause diarrhea, hand-foot syndrome, and rarely chest pain. So this was something which I had taken in one of my classes, in my offline classes. So what essentially happens is when you are giving, there is a difference in the toxicity for infusion versus bolus 5FU. So infusion is something which is going to be running. Okay, so infusion is something which will run in an IV line. So when you have runs, so that is the way to remember the toxicity which is associated with your infusion 5FU. So what are the things that will be caused by running? So runs is another name for diarrhea. So it will cause diarrhea. The next thing is whenever you are running, you will use your hand and feet. So you will get the HF syndrome. Okay, and when you are running hard using like that, you may get your chest pain or your myocarditis. So these are the three things which are common with your infusion. Okay, the question was patient treated with CRC comes with neuropathy. Which drug is the most likely cause? Okay, now this is going to be more complex because you can have neuropathy associated with other drugs as well, including oxaliplatin. Okay, so in such a scenario, probably I will go to choose your oxaliplatin because in colorectal cancer, capecitabine and 5FU are not generally known to cause so much of your neuropathy. They can cause, but in general, if you look at it, if that is the question that has been asked, someone has put up in the chat box, if it is said that it is due to colorectal cancer, patient has been treated, then I will say the probable choice is going to be your Folfox regimen, where you're going to use your oxaliplatin. Capecitabine and 5FU generally cause more of bone marrow toxicity and mucositis when they are given as bolus regimen. And capecitabine will cause your hand-foot syndrome. This this runs basically your diarrhea and your hand-foot syndrome, which are going to be caused rather than the other type. Okay, so that is going to be the one that is important for us. So if the question has been in a patient who is treated with colorectal cancer, then I will go for the choice as oxaliplatin. Bolus 5FU, as I was telling you, is the other type that will cause myelosuppression as the main toxicity and also mucositis. Okay, the two M's will be caused by bolus 5FU. So bolus will cause the bone marrow toxicity, and then you will have the capecitabine and the infusion 5FU, which will cause the runs. It will cause the running, basically your diarrhea, your hand-foot syndrome, and your other type. Okay, so that is going to be the difference between the two types of what you can say as infusion versus 5FU and your bolus 5FU. There is going to be a difference in the toxicity profile that is associated with it, right? Okay, so cells that suppress the anti-tumor activity, they are all the following except. Now this is a little tricky question. Okay, now if they have given as without this except, okay, if the option is given without the except, okay, when you have the options here without the except, then the best possible option will be the myeloid derived progenitor cells or the myeloid derived suppressor cells. So they are the ones that are very, very involved in the suppression of your anti-tumor activity. On the other hand, you also have the T reg cells and the CD4 plus cells. both of these CD4 cells also become the Treg cells or the IREG cells or the immunoreg cells as we call them when they express the CTLA4. So basically all of these cells, what they happen is there is something called as immune surveillance which is going on in the body. So any tumor which is going to be present, so the tumor cells are going to be found out by the immune system. So there are some cells which help in preventing this. So these are the ones that suppress the anti-tumor activity. So these cells importantly are your regulatory T cells, your CD4 positive T cells when they have the CTLA4 which has been expressed in them, and then you also have the myeloid derived suppressor cells which are derived from the myeloid progenitor cells. So all these three will have an action on the anti-tumor suppression activity. On the other hand, your CD8 plus T cells are going to be your cytotoxic T cells, which are always going to be your anti-tumor cells. So they will promote the anti-tumor activity. Okay, so that is the no except for that. So if there is no except, then I will probably go for myeloid derived progenitor cells, which is directly given as a statement, cells for suppressing anti-tumor activity. But in fact, if you look at it, all these cells, okay, all these cells will also cause a suppression of your anti-tumor activity. That is what I want you to remember. But for your exam, just remember it as MDSC. Direct answer will be MDSC. If not, then you remember that CTLA4 positive CD4 cells and your Treg or your regulatory T cells, both of them also suppress your anti-tumor activity. So they are also some things which are going to be important. So here the answer is going to be marked as something, but remember in patients it can be the other one as well. So CD8 definitely does not, CD8 plus cells definitely do not have any suppression. So which cells directly suppress, if that is the question, then it is going to be your MDSC or your myeloid derived suppressor cells. The name itself is actually myeloid derived suppressor cells. That itself is the name. So that will be the direct answer. So if that is the way it has been asked, only one single answer, then this will be the correct answer for this particular question. Okay, right. So this is again a simple question. I think most of you would have answered this. What is the gene editing method? Yes. So the answer is the CRISPR, clustered regularly interspaced palindromic repeat sequences. So that is a method, that is a revolutionary method of gene editing which is being done now. So you take up lot of areas of advancements have actually been taking place in the gene editing or in the management of your genes. So if you look at it, CRISPR is one of the things which uses the Cas9, the caspase-9 system is going to be used. So CRISPR using the caspase-9 system, that is the most accurate or the best gene editing system which is available today. You also have the old systems which initially use the meganucleases. So you look at it, they will act as a non-homologous end joining, meaning they do not have a high fidelity. They do not have a high fidelity system, meaning they do not exactly cleave the cells at the areas where it is wanted. So that is the thing which is different. Okay. So when you look it up, CRISPR or Casper, CRISPR, Edge, Rigid, and Casper. Okay, fine. So if that is the case, then I will still say the answer is going to be CRISPR, because CRISPR is the revolutionary system that has come up, and CRISPR is going to be the most important or the best gene editing system that we have got currently for the management of or for the excising. See, what it basically does is when you have a break, it puts the template exactly at the place where you want it to be done. So that is the function of your CRISPR or your Cas9 system. It's a revolutionary technique, and this technique has actually gotten the owners the Nobel Prize also in medicine. If I'm not wrong, a couple of years back, they got the Nobel Prize in medicine for that. Casper, as far as I know, is no known technique is there known as Casper. Casper is just going to be a something which is a variation of your Cas9 system. So the technology is known as CRISPR using the Cas9 system. So the answer is going to be CRISPR using the Cas9 system. That is the best gene editing method that we have currently. So going on to the next question. So cell-to-cell addition, this is a straightforward question in cancer that is going to be mediated by your E-cadherin. So here we have VEGF, EGFR, FGF, each of which has got a different function. You have got the pathway, you have got various steps in carcinogenesis. So in that, E-cadherin is going to be important in preventing your, in bringing about your contact inhibition. Basically, when two cells are there, when two cells come into contact with each other, that will trigger the activation of your E-cadherin, and so the cell growth is prevented further. But degradation of E-cadherin, when it happens, the cell growth is still going to be sustained and it keeps continuing to grow. So contact inhibition, that is the function that is majorly important in, which is inhibited in many cancers, and this is done, and this is mediated by E-cadherin. Contact inhibition is something which is mediated by E-cadherin. So the contact inhibition function is modified by the Merlin gene product, which is found in your NF2 gene. So the NF2 gene product is Merlin. So that promotes the binding of E-cadherin to, EGFR and prevents the mitogenic signals. So whenever you have a NF2 dysfunction or a Merlin gene dysfunction, or when there is an E-cadherin dysfunction, any of these three will cause the loss of contact inhibition. So that when it happens, then the cell-to-cell adhesion contact inhibition is going to be lost, and that will make the cancer cells to continue to grow irrespective of contact being present or absent. Okay. Now, which is the cancer which is not associated with a microbial etiology? Is it prostate cancer, lymphomas, gastric cancer, or Merkel cell carcinoma? Some of you may be aware of, the common ones. Okay, many of you are already answering it right here. So here we have, lymphoma. What is the lymphomas that are commonly associated with, organisms? Everyone knows H. pylori and gastric cancer. Okay, everyone knows about H. pylori and gastric cancer. What about Merkel cell carcinoma? Okay, lymphoma is going to be, one is the Epstein-Barr virus in your Burkitt's lymphoma. What other lymphoma is there which is associated with your organism? One other organism, can you name? Yeah, malt lymphomas with H. pylori again. Other one? Any other thing you guys are aware of? Perfusion associated is a variant. It is considered to be an age-defining illness. So what I am looking for is actually the HTLV1. So the HTLV, which is associated with your primary cutaneous lymphomas, cutaneous T-cell lymphoma, that is going to be associated with your HTLV. So that is another lymphoma which is associated with it. So here you have got the various organisms which are there, each of which is causing one etiology. Prostate cancer is not associated with it. You got your infectious agents like HPV in carcinoma of the cervix, HPV in oropharyngeal cancer. You got your, Burkitt's lymphoma associated with EBV, HTLV in your cutaneous lymphomas, H. pylori in gastric carcinoma, and also in your malt lymphomas, and human polyoma virus 5, HPYV5 as it is called as, in your Merkel cell carcinoma. So these are all involved in your viral orthogenesis as far as your management, as far as the carcinogenesis is going to be concerned. Okay. So cell cycle sequence, clear cut, everyone knows the answer. It is G1S and G2M. Okay, so this question I'm just going to discuss about the cell cycle a little bit. So we have to know that there is a G0 or a resting phase which is going to be present. And then you have the G1S and the G2. All these together are known as the interphase. Okay, so G1S and the G2 together are what is known as the interphase. G1S and G2 together are known as the interphase, and then it is followed by the mitotic phase. Okay, G0 is the resting phase between the cells. Okay, so here you got the mitotic phase. The G1S and the G2 together are known as the interphase, and when it goes outside the cell cycle, it goes into the G0 phase. So the G0 phase is the one which is most commonly, most of the cells are going to be present in the G0 phase. Most of the differentiated cells actually do not ever come back into the growth cycle at all, into the cell cycle at all, once they attain the differentiation, like muscle cells, cardiac cells. These are supposed to be some of the cells that do not go back into the cell cycle after they become differentiated. But we do know that there are some stem cells which are found which can differentiate. So some telomerase inhibition, all this can cause it to go back and regress into cells which then become stem cells. That is all the recent research which is coming up. I thought I will just add a page here, add a part here with regard to your cell cycle specific and your cell cycle non-specific drugs. So when you take up here the most important phases which are going to be important, which is the thing which is going to be most sensitive to radiation. So when you take up the G2M phase, this is the one which is most sensitive to radiation, and S phase is the least sensitive as far as the radiation is going to be concerned. So the most sensitive and this one, so dividing cells are going to be there in the mitotic phase. So that is why your G2M is the phase where you will have high sensitivity to your radiation. So that is why it is going to be your most radiosensitive. Here also it is put up, see, the color coding is given here. So the most radiosensitive phase is going to be in the G2 to M phase, and the least radiosensitive phase is going to be in the G0 phase and in the phase of DNA synthesis. Among this, the phase, if they ask you as a single best answer, then the answer is going to be in the S phase. The S phase is the one which is going to be least susceptible to radiation. The S phase is the one which is least susceptible to radiation. Then you have the other drugs which will act. So here the question can be on the cell cycle non-specific drugs. So these the two agents which are important are the alkylating agents, the platinum agents, and along with this you can also think of the anti-tumor antibiotics as well. So you will have the anti-tumor antibiotics as well. So antibiotics, the alkylating agents, and your antibiotics, you have your anti-tumor alkylating agents, and then you have your platinating agents. These three are the ones which are going to be cell cycle non-specific. So when you take up the S phase specific drugs, those are all going to be your anti-metabolites. So anti-metabolites, basically they are all variants of your adenine, guanine, cytosine, thymine, pyrimidine. So antipurines, antipyrimidines, they are all going to be there. So that is why in the S phase they will act, like your 5-FU, your methotrexate, hydroxyurea, the cytarabine, gemcitabine, etoposide. All these are the drugs that will which will kind of interfere with this. G2 to M will be the phase where you will have your mitotic spindle poisons which will act, because your mitotic spindle poison is going to be important in your your mitotic spindle poisons are going to be your taxanes, your vinca alkaloids, and also your etoposide. All these are going to be the one which will be acting in the G2 to M phase. So G2 to M phase is where you will have the action of your taxanes, vinca alkaloids, and your etoposide. So these are some questions that may come to you from your cell cycle. Some related questions I thought which are going to be important for you from this particular question. So triage in cancer patients. Okay, so triage in cancer patients in the COVID era, it depends on all the following except. Does it depend on, what does it not depend on? So does it depend on the biology, the urgency of the surgery, the available resources? Does it depend on the vaccination status? Most of you would have gotten this right, though it is, all of us know that there is no role for vaccination status in deciding whether the patient is going to have a particular treatment or not. So if you look at the treatment, you basically classify the surgeries are high, medium, or the low priority. These are the ESMO guidelines which were given on triaging of cancer patients. So when you take up a high priority system, what you mean by high priority is which is going to be immediately life threatening. It means all urgent or emergency scenarios are going to be high priority, clinically unstable, life threatening, that kind of thing. Or the other thing is there is a substantial benefit in overall survival or in the quality of life. So substantial benefit in overall survival or quality of life or emergency or urgent scenarios, that is going to be high priority. So what is going to be low priority? One is there is no benefit in QOL or in overall survival. So no benefit in overall survival or quality of life. And then if there is going to be a stable patient, so then that is going to be a low priority surgery. Anything in between these two. So non-critical surgeries, but which needs to be done beyond 6 weeks will cause an impact in overall survival. So substantial benefit, if it is there, then you make it as a high priority. There is some benefit, and especially when it is more than 6 weeks, there may be a decrease in your overall survival or in your quality of life. Then that will make it as a medium priority. Your low priority is going to be the one where there is no real benefit of doing the surgery. Then that is why you will classify. So where is the question of available resources? Because even though you may want to treat the patient a particular way, let's say you want to give radiation for a patient, but then if the radiation is not available, you may be forced to choose surgery because of lockdown or other reasons. So that is where you will have the available resources that come in. The urgency of the surgery, all of us know. The biology of the cancer is also another thing. Tumors which are like say a pancreatic head carcinoma, these are things which are going to be highly important or highly aggressive tumors. So these tumors definitely will want to treat them immediately. So that is how you will triage the patients in the COVID era. So vaccination status has got no role in this particular decision making. Right. So the mechanism of aortic aneurysm, this is a straightforward question. This is loss of elastic fibers in the media. It is not the adventitia, it is the loss of elastic fibers in the media which is going to be important. So reference is given in your subsequent previous edition, not in the current edition. So loss of elastic fibers in the media, in the tunica media, is going to be the important factor which is going to be there. So what is the difference between a pseudo aneurysm and a true aneurysm? Anybody? Classical differentiation, pseudo aneurysm versus true aneurysm. What is going to be the difference, major difference? Yes. So when all the layers are going to be involved, that is going to be a true aneurysm. So when all the layers of the wall are going to be involved, that is going to be a true aneurysm. So why then are we talking about loss of elastic fibers in the media only here? Should be in everywhere, no? But you have to remember that the major reason for why it happens is there is a loss of elastic fibers in the media, but then the dilatation happens to involve all the layers, and that is why it is a true aneurysm. So true aneurysm is something which involves all the layers, and usually it is due to loss of elastic fibers in the media. Okay, which does not occur in acute response to injury. I think this was the question that was asked, including the options which were given. Okay, so for this question, what is the answer? D and A, two answers have come. Okay, so the answer is actually B. Okay, increased amyloid. Okay, now there is some controversy with this also. I will come to that in a particular minute. What I thought I will say and put it up here is, what are the acute phase reactants? Now there are some things which are known as the positive acute phase reactants. What it means by positive acute phase reactants is all these are going to be increased. When you say positive acute phase reactants, they are going to be increased. So positive acute phase reactants are going to be increased. So what are the agents which are going to be increased? We're going to have CRP, procalcitonin, ferritin, fibrinogen. The other things are not so important. And then you have your serum amyloid A. This is where the controversy comes in. Was it the question that came as increase in serum amyloid A, or was it something that was mentioned as amyloid alone? So that is one question that we have to have in mind. I don't know, because I have not obviously gone to the exam, but then you guys will have to figure it out. That's why I thought I'll put up what are the ones which are increased and decreased. The negative phase reactants are going to be decreased in your acute scenarios. So this includes albumin, prealbumin, transferrin, and your antithrombin and retinol binding protein. All these are going to be the ones which are going to be decreased. So albumin, prealbumin, transferrin, antithrombin, and retinol binding protein, all these are going to be decreased. So these are the negative acute phase reactants. So positive acute phase reactants involve procalcitonin, CRP, ferritin, and fibrinogen. So if you look at it here, you will have a decrease in, your transferrin, because it's a negative acute phase reactants. Pyrexia will be there. Again, albumin is a decreased because it's a negative acute phase reactants, whereas amyloid is not going to be increased. You will have the serum amyloid A, which may be increased, but on the other hand, you will find that there will be pyrexia almost always in a scenario of acute response to injury. So that is also one of the factors which is mentioned. So this was the 2005 journal where it was clearly mentioned what are all the things that get acutely elevated and which are not elevated. That was very clearly mentioned in this. Okay, right. So structures which are not passing through the superior orbital fissure. This is a simple question for all of you. The answer is the ophthalmic artery. The vein, the oculomotor nerve, and the abducens nerve, all of this are going to pass through the superior orbital fissure. So this is the diagram of your optic foramen and your this one. Through the optic canal and foramen, you have the optic nerve, and along with it, you have the ophthalmic artery. So both of this will go through the optic canal. The optic nerve and the ophthalmic artery go together in the optic canal. The superior orbital fissure, you will have the superior and the inferior ophthalmic veins. So both of them will pass the oculomotor nerve. Then you have your abducens nerve, parts of the fifth cranial nerve. You have the fourth cranial nerve. So the 4, 5, 6 nerves, all the nerves essentially pass through your superior orbital foramen or fissure, except for the optic nerve. So the optic nerve or the second cranial nerve is the one that passes through your optic foramen along with the ophthalmic artery. So these are the two major structures that pass through there. All the other ones are going to pass through here. Okay. So next question is, hypercalcemia is not seen in. So this was again a clear-cut answer. So hypercalcemia is something which is not seen in celiac disease. Okay. So hypercalcemia is not something which is seen in celiac disease. In all other things, you will get your hypercalcemia. Why? Because you will find that ZDS is often associated with your hyperparathyroidism, leading on to hypercalcemia. You will find thiazide diuretics will cause calcium absorption, leading on to hypercalcemia. And again, you will find that antacids contain, many of the antacids actually contain calcium salts. So that also will lead to hypercalcemia. On the other hand, celiac disease clear cut is something that will cause a calcium malabsorption, which is characteristic, along with hypocalcemia and decrease in the bone mineral density, leading on to hypocalcemic features. So that is why hypercalcemia cannot be seen in your celiac disease. All other areas you will have hypercalcemia. Right. Pectoralis minor is supplied by. What is the answer to this question? Pectoralis minor is supplied by. Is it the lateral pectoral nerve? Is it the medial pectoral nerve? I mean, axillary and thoracodorsal, you can forget. All of you know that those two are not the answers. It is between the lateral and the medial pectoral nerve. The answer is the medial pectoral nerve. Okay. So the answer to this question is the medial pectoral nerve. The medial pectoral nerve arises from the medial cord of the brachial plexus. The name comes because it is the medial cord of the brachial plexus. It pierces both the pectoralis minor and the pectoralis major, and it supplies both these vessels. Okay. On the other hand, you will find that the lateral pectoral nerve supplies only the pectoralis major. So the pectoralis major is supplied by the medial and the lateral pectoral nerve. On the other hand, your medial pectoral nerve is going to supply both the pectoralis minor and the pectoralis major. Two differences. So the pectoralis major is supplied by both the nerves. The pectoralis minor is going to be supplied only by the medial pectoral nerve and not by the lateral pectoral nerve. The other point that may come as an MCQ question is, in your anatomy, the medial pectoral nerve is your lateral nerve. Okay, it is going to form one of the landmarks to identify your axillary vein that lies about 2 to 3 centimeters above and deep to the medial pectoral pedicle. So the medial pectoral pedicle is a landmark for the axillary vein which lies above 2 to 3 centimeters superior and deep to the medial pectoral pedicle, and it lies lateral to the lateral pectoral nerve. So why is it called as a medial pectoral nerve? Because of its origin from the medial cord. The names of the medial pectoral and the lateral pectoral nerve. Why is an MPP called as a medial pectoral nerve? Because it arises from the medial cord of the brachial plexus, but it lies lateral to the lateral pectoral nerve. Okay, so it lies lateral to the lateral pectoral nerve. The lateral pectoral nerve arises from the lateral cord, and the name is only because of the origin. It does not have anything to do with the anatomy. It has to do with the origin of the nerve. So that medial pectoral nerve arises from the medial cord. The lateral pectoral nerve arises from the lateral cord. The lateral cord gives rise to the lateral pectoral nerve, which only supplies the pectoralis major, the clavicular head, to be very specific. On the other hand, you will find that it supplies the clavicular head of your pectoralis major. The medial pectoral nerve, on the other hand, is going to supply your pectoralis minor and your pectoralis major. Both are going to be supplied by it. Okay, so this is a clear-cut question, but then still a lot of extra points that you can learn from it. So ABG, not really many people's cup of tea, but then there are some clues that you can look at it. So the first thing, whenever you're talking about your acid base, whenever you're talking about it, so you look at the pH value. So this pH value is going to be something which will tell you whether it is acidosis or alkalosis. So the normal pH values is what? What is the normal pH? The normal pH is going to be somewhere between 7.35 to 7.45. So all of us know that high values are going to be indicative of an alkalosis. Okay, low values are going to indicate an acidosis. So all of us know about this. So now we have established when it is 7.5, it is going to be an alkalosis. Then we have to look at the levels of PO2 and PCO2. Now, before doing that, when you have alkalosis as one value, then the next thing that you have to look at is the bicarbonate. Okay, the simple clue to remember that is whenever you have to think about alkalosis and acidosis, then you look at the bicarbonate level. So when you have bicarbonate, it's going to be normal, then or it is going to be slightly on the higher side, then you are essentially ruling out a metabolic cause. So here you are finding out that the value is going to be 21. So you got a PO2 which is kind of high, you got a PCO2 which is low. So all of this indicates that the patient is probably hyperventilating, making the diagnosis of a respiratory alkalosis. It is not very greatly elevated, it is a marginal elevation. Alkalosis is there. PO2 is found to be normal level. PCO2 is found to be low or normal, and bicarb is also low. Bicarb is also high. So when you have all of this together, you arrive at the diagnosis of a respiratory alkalosis. On the other hand, in your metabolic acidosis, so when you are talking about your metabolic acidosis, so whenever you have metabolic acidosis, what you will find is bicarbonate will be low. So a low bicarb indicates a metabolic acidosis. Always it will be having a metabolic acidosis. That will be the cause. Okay, so these are some clues in which you have to. The bicarbonate here is actually normal. It is neither low nor high. Okay, so here what we are having is nearly a normal level of bicarbonate, but slightly elevated. And again, the CO2 levels are low. All of this makes it a diagnosis of your respiratory alkalosis. Okay, so that is how you will determine whether it is going to be a respiratory alkalosis or your metabolic alkalosis or acidosis. So look at the pH value, clear it as alkalosis or acidosis. If most often the combination will be given for a metabolic acidosis or they will give it for a respiratory alkalosis. These are the two things that will be commonly asked. This is another trick that I will tell you. Metabolic acidosis due to an increased acidity in the blood due to various things, sepsis, everything, that kind of scenario they will give, asking you a metabolic acidosis scenario. Other thing is they will ask you for a respiratory alkalosis scenario. Very rarely they may give the PO2 values to be very low and the PCO2 is found to be elevated. When they give that, these values again differ across various, this one. That is why I have not put up the values here. This is not really my cup of tea. I've just given you the basic clue on how to do it. Okay. So what you can do is just look up with the normal values to remember PO2 of 8 is though a high value. So that rules out essentially a a respiratory acidosis as a cause. So how to assess the resection margins intraoperatively? This was another interesting question that came. Okay. Now I almost had the answer marked as frozen section, but the correct answer for this particular question is actually something known as the margin probe. I have not used it. I just read up on it after I saw this particular question and I found it's actually an FDA approved device. Oh, the question is all except. Okay. All except was the question. In that case, it will be HP. In that case, it might be likely a Raman spectroscopy, probably. In that case, I will probably put it as a Raman spectroscopy. So histopathological examination, see your frozen section is another form of histopathological examination. IHC can be done on a frozen section as well. Okay, IHC can be done on a frozen section as well. As far as I know, Raman spectroscopy is not something which is used for intraoperative analysis. As far as I know, okay, fine, I will look into it. But when I looked up into Raman spectroscopy, I couldn't find any mention of intraoperative frozen section assessment margins. So yeah, I just thought I'll put in a word with regard to this. As far as I know, Raman spectroscopy is not something that is used. So I will check it up because if it is okay in Roshan Lal Gupta it is given. Okay, fine. So no, it is based on a different system as far as I think, because spectroscopy implies light and this one is with regard to an impedance. It does not depend on the Raman spectroscopy is not the principle behind the margin probe. What you basically do is you just use this device and based on the impedance character that you get, you will get this kind of formation, and this kind of formation happens due to the negative or the difference in electromagnetics that you have. That is where you have the difference. So margin probe is definitely right. Frozen section is also definitely right. HPE and IHC, well, if you look at frozen section as a form of HPE, then I will say this is right. But then if the Raman spectroscopy is given, then fine, I will take that as the answer. I was not able to find any reference to Raman spectroscopy in the things that I could research and find out. Okay, so if that is the case, then I will go back and change the answer to HPE and IHC if it is given in some reference textbook. Right. So the next question was something on your organ plasma photocoagulation. So this is a very clear-cut answer. When you have a something called as oozing from the raw surfaces, that is the characteristic place where you will use your organ plasma photocoagulation, which is going to be used. So organ photocoagulation is something which is going to be used for raw surfaces. There are Taylor 39 edition. What is Taylor? Taylor Francis you're talking about. Okay, let's go to the next question. I will accept your recent advances. Okay, Taylor and Johnson. Okay, fine. Great. I have not heard of the technique. In fact, margin probe was also something which I had not heard of till I actually did some research on this. So you also learn when you are teaching. The best way to learn is to teach. So that is what I'm learning. Raman spectroscopy, I will again look at it and I'll probably publish it when I'm releasing this as a PDF. I will put it up with that. Couple of answers have been different, so I will just do that. So argon plasma coagulation is used in heavy arterial bleeds. You cannot use your APCs. Where you will use it, variceal bleedings, again it's going to be usually a spurting vessel, so you may not be really be able to use it. The characteristic use is going to be in when you are having a diffuse raw area which is going to ooze. So some points with regard to your argon plasma coagulation. It is an electrosurgical technique. They may ask you the principle. So this is an electrosurgical technique. It is a non-contact technique. So here you can see that the electrode is here somewhere inside, and this is the surface which is there. So once the probe is activated, you have your, argon gas which is going to be circulated around here. So you can see the probe here, and then you got the circulation of argon gas around it. So once you activate the electrode, this will get activated, and this will form a ray of light kind of thing which will be going there. You can see this, argon beam which is going there. Once it is activated, almost a precise beam, you can use it for cauterization, especially useful as you can see here in the cauterization of the raw surface of the liver in case of partial nephrectomy. Those are the areas where you have a diffuse ooze. So those are the places where you can definitely use this argon plasma coagulation. Okay, so most commonly used in your liver surgeries and also in your endoscopy. Now this is an endoscopic picture where especially useful in an entity called as GAVE. Okay, gastric antral vascular ectasia. So GAVE is something which is known as your gastric antral vascular ectasia. That is one characteristic use which was mentioned in multiple textbooks as a use for your argon plasma coagulation. So any diffuse ooze when you do not have a point bleed, that is where you have the maximum use for an argon plasma coagulation. This was a straightforward question. I think most of you will know this answer, something this is asked repeatedly in general surgery. So what is the infection which is a contraindication for skin graft? It destroys the fibrin and inhibits the skin graft. What is the answer? Staph aureus, MRSA, Streptococcus, or Pseudomonas? Okay, so all of you are aware of the answer. It is group A, beta hemolytic Streptococcus. So many of you will generally think a Pseudomonas infection is something which is a contraindication for a graft. Not really. Pseudomonas infection is a relative contraindication in current world where you have a lot of anti-Pseudomonas antibiotics which are available. It is no longer a contraindication. Streptococcus, on the other hand, is going to be an absolute contraindication for a graft because the beta hemolysis that it causes will cause fibrin degradation because of the enzymes, the streptokinase enzymes. It will cause fibrin degradation and hence a graft loss, and hence it is a contraindication. Straight answer taken from Bailey. So that, my friends, brings us to the end of the session of discussion on your AIIMS questions.